2, 1. Please start, sir.
Yeah, very good morning, doctors. I'm Srinivas from Bayer. Thank you very much for taking out your time today to attend this scientific meeting. Today we have one moderator and two speakers, two eminent speakers. First, I would like to introduce our today evening's moderator, Dr. Lakshmi Prasanna Madam. She is currently working at Maxivision Visakhapatnam. She has done vitreoretinal surgery fellowship from Shankar Foundation, and she worked as consultant as well at Shankar Foundation. And after that, Madam worked at Vision Tree Hospital, and Madam has more interest about the retinal surgery as well as intravitreal injections. Madam had various memberships in various renowned ophthalmic bodies. So, with that, Madam, please take the meeting forward, Madam.
Thank you, Srinivas. Good evening, everyone. Thank you, Bayer, for giving me this opportunity. So daily we see a lot of patients coming to our OPD with the diabetic macular edema, wet AMD, BRVOs, vein occlusions, and PCV. So there are multiple anti-VEGFs available in the market, and there is a lot of a discussion in our brains which injection to give. So today's discussion focuses mainly on the Eylea and its evolving role in retinal practice. From diabetic macular edema to wet AMD vein occlusions, aflibercept has significantly influenced the treatment strategies. So I hope we can explore not only the evidence from major trials, but also practical real-world experiences regarding efficacy, durability, switching strategies, and patient compliance in today's discussion. So without much delay, I would like to invite Dr. Divya Madam. So she is currently working in Dr. Agarwal Eye Hospital, and she completed her fellowship from Shankar Netralaya, Chennai, and she got 10 publications in her name. So, ma'am, over to you.
Good evening, everyone. I think I'm audible. Am I audible?
Yeah, you are audible.
Today, my topic for today is 1 minute. So it's evaluating the need for change, evidence and insights on anti-VEGF therapies. So I would like to briefly talk about what are the anti-VEGF drugs we are having and how potent they are. So currently, the anti-VEGF treatments which we are having are mostly for wet AMD, diabetic retinopathy or diabetic macular edema and vein occlusions. And we have different drugs like bevacizumab, ranibizumab, aflibercept, rolosozumab, and faricimab. We know that there is no cure for wet ARMD, but timely treatment will actually achieve AMD treatment goals. So that treatment goal is drying the affected eyes. So that is by inhibiting the new blood vessels which leak the blood and fluid, and that will improve the visual acuity, or it maintains the visual acuity over long periods. So in real world settings, we have significant gaps, and there are also challenges which are posed because of different barriers for achieving these goals. So what challenges are we facing for this is actually introduction of anti-VEGF growth factor is a significant impact because it has reduced the visual acuity loss due to neovascular ARMD. And the challenges when we use these drugs in real world scenarios is that there is a significant inter-individual differences in response to these anti-VEGF drugs. And also this availability of multiple anti-VEGF agents, so with different molecular configurations, and this response to anti-VEGF therapy has found to be dependent on various factors. So it includes different things like patient's age. So it also has lesion characteristics, duration, the baseline visual acuity with which the patient presents, and the presence of any particular genotype risk alleles. And then there is no consensus as to how to classify this optimal response, or is there any lack of response for this with these current therapies which are available. So how we define a response to an anti-VEGF drug? So basically there are two responses. One is primary response and the other one is the secondary response. So primary response is when we are seeing the patient after 1 month following the last loading dose, and the secondary response is anytime after the 4th visit. So secondary responses do not mirror, or they cannot be predicted from the primary phase. So there is something called ceiling effect that is being currently seen with the drugs. That is, there is some limitation of functional metrics, that is more than 5 letters improvement and maximum of around 7-letter improvement in this baseline visual acuity, because that is combined with different parameters to determine the response of these anti-VEGF drugs. So the change in visual function is usually assessed by the visual acuity measurement at baseline and also all the follow-up visits where the patient is coming. Along with that, we are doing this OCT assessment every time the patient comes, so that we can see the macular morphology accurately, and we can assess it all the time whenever the patient comes for the follow-ups. So we do OCT and all these investigations, and the other invasive investigations like FFA and ICGA usually they are reserved for certain clinical cases and clinical features such as PCV and RAP lesions. So where the response of these drugs is very suboptimal. So the response is again classified into different types depending on the primary phase response. So this is good response or partial or poor or a non-response. So again, this is having an anatomical response and also a functional response. So morphologically or anatomically, when we say it is a good response, there should be an absence of any intraretinal or subretinal fluid along with any intraretinal cyst. And also the central retinal thickness, there is a decrease in this by at least 75% from the baseline values. Then we say that it is a good response of the anti-VEGF drug. So when it comes to the functional improvement, so there is more than 5-letter improvement from baseline. So we pay more to the we pay more attention towards the morphological features and visual acuity response. So partial response, we classify that as a reduction of any central retinal thickness between 20 to 75 of the baseline values, and there is certain persistence of SRF or IRF or any intraretinal cyst, and any appearance of newer intraretinal cysts or intraretinal fluid or subretinal fluid. So here the visual acuity change is usually comparatively less, that is around 1 to 5 letters from the baseline. So we classify poor response between 0 to 25% reduction in the central retinal thickness, and there is persistence of SRF or IRF, and also newer SRF, IRF or intraretinal cysts will come up. Here the change in visual acuity is not that significant, or it is not observed much because it is in the range of 0 to 4 letters. So non-responses where we are not seeing any response or any change in the central retinal thickness or in the SRF or in the IRF, and also in the patients of AMD, we see the PED compared to the baseline. So there is no change in the letters also, or you can also sometimes see that there is a decline in the visual acuity from the baseline. So in these scenarios where we are using the basic drug or the initial drugs like bevacizumab and ranibizumab, switching to a newer anti-VEGF agents is giving us a hope, or is it a hype? So we have certain real-world studies with faricimab in NAMD, and that has shown some limited visual gains. So we are taking a comparison between faricimab and also aflibercept. So when we are taking that, after 3 injections of faricimab, the mean visual change from the baseline, either the patient is treatment naive or they are switching from aflibercept. So when they are switching from aflibercept, there is no much difference in the improvement of visual acuity because it is around 2 letters. When the patient is treatment naive, it is having some significant effect, but the number of patients are having this visual gain is comparatively lesser group of people. So after 4 faricimab injections, there is no significant difference in the visual acuity gain. So when we are switching patients, around 92% of the patients who were switched from the faricimab, they have discontinued because due to insufficient efficacy. That is, they are unable to achieve this efficacy or the visual acuity by taking at least 3 injections. They are not satisfied with the injection of faricimab because the change what they are seeing is taking them more in number of injections. So from the baseline to month 6, 60% of the patients are discontinuing this drug, and 92% discontinued because it is insufficient efficacy, and 73% have switched back to the drug because they did not find that faricimab is not effective. So 71% of the patients who are switching between aflibercept to faricimab, they have remained on the 8 weekly intervals from the baseline. So these are all real world studies. So in Kishi et al. Study, they have seen that 55 eyes were previously treated with aflibercept. So again, they have switched after 8 weeks. Then faricimab with the interval based on this treat and extend regimen interval. So before they are switching, there is no loading dose which was given to these patients. So after 3 faricimab injections, patients have seen that there is no change in any visual acuity, or there is a mixed outcome in the anatomical characters. That is, choroidal thickness, central choroidal thickness has not significantly reduced, but central retinal thickness has significantly reduced. So more than 70% has a treatment interval of less than 6 weeks. So they needed more number of injections. So after 3 loading doses, there is significant observations which were seen as compared with aflibercept. So Hara et al. Has seen that after 3 injections, there is a significant visual improvement in aflibercept group when compared to the faricimab group. So also the mean central retinal thickness has markedly improved from baseline to 3rd month in both of the arms, that is aflibercept arm and also the faricimab arm.
Madam, any issue?
Yeah, actually my slides are not moving, so that's why. Yeah.
Fine.
So we have also seen that Bailey C et al. It has seen that they have shown that there was a prior IVT treatment. So 72.1% of these previously treated eyes were switched from aflibercept. So they have a limited improvement in these intervals in DME patients also. As we have talked about the neovascular AMD patients, also the improvement in DME patients were also less in these groups. So 86% of these patients are switched from aflibercept, and despite multiple injections of faricimab, patients are only maintained at 8 weekly intervals. So when we are evaluating the effects of, there is a brief report which was published in JAMA Ophthalmology. So evaluating effects of switching antivascular endothelial growth factor drugs for AMD and DME. They found that these eyes which are meeting this switch from aflibercept to faricimab, the improvement in the visual acuity and retinal thickness were more if they're switching back to their initial drug compared to the other drug which they were switched before. So there have been different approaches have been attempted in an effort to improve the patient outcomes. So targeting additional pathways other than VEGF, is it actually beneficial is the question in this scenario. So there are different group of drugs which are actually targeting different pathways. First of all, aflibercept is actually targeting anti-VEGF pathways, anti-VEGF A, B, and also the placental growth factor. And faricimab, as we have seen, and it is affecting anti-VEGF A along with Ang2 pathway. Brolucizumab and ranibizumab, they are targeting anti-VEGF A only. So when we are taking this aflibercept, so aflibercept is targeting VEGF A, B, and placental growth factor. So inhibition of placental growth factor by aflibercept is more important because placental growth factor plays a very important role in angiogenesis in these patients. So in Ruby and Onyx, there is no, they found that there is no additional benefit with the potent Ang2 inhibition in combination with aflibercept. So the Ang2 inhibition did not provide any additional benefits to the patients as compared to the aflibercept monotherapy. So what is the conclusion? So faricimab is actually down-regulating this Ang2, which is acting on the Tie2 receptors, and Ang2 as it increases the angiogenesis, neovascularization in these patients, and the Ang1 is decreased in the patients of NAMD and DME. So that's why they have developed a pathway that also has inhibition for Ang2. But in real life, in TENA and Lorcine studies, so faricimab has some effect in the visual acuity. So aflibercept 2 mg for mean BCVA change also could be seen, but what visual acuity outcomes were seen were it is non-inferior to the aflibercept 2 mg. So both the aflibercept and faricimab are equally effective in decreasing the edema, and also the visual outcomes are better. So Avenue clinical study. So this is showing that ranibizumab and faricimab have achieved similar levels of plasma Ang2 inhibition after one injection. So there is no additional benefit of Ang2 inhibition which is provided by faricimab, because the main inhibition for the pathogenesis of this diseases is VEGF. So faricimab has failed to meet the primary endpoint of superiority to ranibizumab, that is BCVA gain at 36 weeks. Levels of Ang2 inhibition is similar to ranibizumab as it was shown in the study, and suggesting that anti-Ang2 mechanism of action, it is having no additional benefit. So VEGF binding arm of faricimab is ranibizumab actually. So role of Ang2 is not been established by many of the studies which were approved by US Food and Drug Administration. So there is a preclinical data that suggests that VEGF is a key driver of Ang2 production. So anti-VEGF drugs can block VEGF-driven Ang2 generation. Aflibercept showed that most durable effect in blocking the effect of human VEGF, which was actually preclinical trials which were done on rabbit models. So the results of the study support that the hypothesis of Ang2 may be expressed secondary to primary insults to retinal vasculature by VEGF. So direct inhibition of Ang2 is not clinically relevant. So this is currently provided by anti-VEGF treatment alone. So conclusion of all this is that VEGF receptor pathway is the main or master regulator in the retinal diseases. So VEGF pathway is a master regulator, as we've seen. So that is decreasing the inflammation and also the neovascularization and also the retinal vascular leakage and edema. So if we are targeting these three things by targeting three different VEGF, that is VEGF-A, VEGF-B, and also PIGF, this is a better anti-VEGF for giving a good response actually. Aflibercept is the only widely approved agent because it is binding to VEGF-1 and 2 receptor ligands. So it is having a better benefit compared to faricimab. Now that there is also a higher molecular weight aflibercept 8 mg. So by increasing molecular weight of that or the molar dose of this anti-VEGF agent, there is also a potential that the patient might get an extended VEGF suppression if it is introduced. And aflibercept 2 mg is actually having good results because it was already proven by many studies, and the safety profile of aflibercept is already proven in different studies, and also it is a long-term process which was there from many years. So have we actually maximized the outcomes of our patients, or can we go further with this disease control? Aflibercept 2 mg, it has set a bar high treatment because it surpasses its standard of care with vision gains, and also durability and safety profile is proven by different studies. Aflibercept targets the key ligands of VEGF pathway, which is a major regulator or the master regulator of the pathological angiogenesis. So if we are targeting these pathways, this pathway is main thing. So it can inhibit this pathway, and results are good with the inhibition of these pathways rather than targeting the additional pathways. So when we are this studies, pulsar and photon studies have been done. So to see the efficacy of the aflibercept in DME and also NAMD. So it has potential for greater and long-lasting effect control underlying disease compared with aflibercept 2 mg. Because aflibercept 8 mg has a sustained disease control, and the number of injections which might take for the patient is also less. The burden on the patient is also less, and also the cost effectiveness and for the patient will be better. Thank you.
Thank you, Dr. Divya. It's a nice presentation. I have a question. Apart from trials in real world scenario, switching from aflibercept to faricimab, and how it affects the vision and sustainability in a patient with AMD, wet AMD?
Aflibercept compared with faricimab, ma'am.
Yes, yes.
So aflibercept actually, it is a well-established drug, first of all, because faricimab has been recently introduced to the market after the clinical trials. So the efficacy was already proven. Visual acuity improvements is after the 3 loading doses, the patient will have at least 3 to 8 letter improvement after this injection, and also 10 to 11 maybe letter improvement in DME patients. And that is actually non-inferior to faricimab. And also the faricimab is also causing a financial burden towards the patient. The patient may not be always affordable for taking faricimab. And we have also seen that Ang2 receptor pathway is playing one role, but it is not significant as VEGF pathway. So when we are able to get a better result with aflibercept, I think it is comparatively better for patient point of view compared to faricimab.
Now the cost is also reduced. I mean, aflibercept cost.
Yes. And the sustainability is also more in some patients where the QR interval, like ALTA study has shown that the interval can be extended to 16 weeks also by aflibercept.
Okay, thank you. And one more question: when VEGF pathway is the master regulator in pathological angiogenesis, then
Yes.
what is the role of newer anti-VEGFs?
The newer anti-VEGFs, as we have seen, they have targeted the additional pathways also, like Ang2 pathways. Maybe they are, the Ang2 pathway is contributing, but it might be a minor pathway which is contributing to that. Aflibercept is any day better compared to the newer anti-VEGFs, and newer anti-VEGFs actually have one ceiling effect as one of the things, because they can achieve the visual acuity to a certain extent, and after that we will not see any improvement in visual acuity of the patient after certain improvement. And second thing is that newer anti-VEGFs, we are also seeing that there are side effects with them, like inflammation was reported by brolucizumab, and also retinal vasculitis was also increased with these. Those are the side effects of the newer anti-VEGF. So I feel that aflibercept is bit better in safety profile compared to the newer drugs.
Okay, thank you, Divya.
Thank you.
Now I would like to call Dr. Shweta Madam. Dr. Shweta, she's a now vitreoretinal consultant currently working at Vasan Eye Care, Vijayawada. And she did her MBBS from Kannur, post-graduation MBBS from Kannur Medical College and post-graduation from Guntur Medical College. And she completed vitreoretinal fellowship from Shankar Eye Foundation. Ma'am, over to you.
Ma'am, you are on mute. Shweta madam.
Thank you, Dr. Lakshmi Prasanna, for the introduction, and thank you, Bayer, for giving me this opportunity. So today we'll briefly discuss about the evaluation of anti-VEGF drugs, molecular characteristics, and how they impact the treatment of various retinal disorders. So before going into the topic per se, we'll just have a brief knowledge about the pathophysiology of diabetic macular edema, proliferative diabetic retinopathy, and neovascular AMD. So as we know that in diabetes, because of the impaired vascular function and impaired retinal blood flow, there is a formation of hypoxia in the retina and also in the choroidal circulation in case of AMD. So this hypoxia causes formation of hypoxia inducible factor 1 alpha, which amplifies the production of VEGF and also placental growth factor. So this VEGF is mainly responsible for increasing the vascular permeability. It targets the occludin proteins, which is present in the tight junctions between the endothelial cells, causing the phosphorylation of these occludin proteins, leads to increased vascular permeability, thereby leakage, causing edema. Similarly, it causes endothelial cell proliferation and migration, resulting in formation of angiogenesis. When I say angiogenesis, it is formation of new vessels from the existing vessels. So also placental growth factor, which acts as a cofactor with the VEGF in angiogenesis, especially in ischemic angiogenesis and vessel wall destabilization. Apart from placental growth factor and VEGF, there are inflammatory cytokines which cause vessel wall leakage and edema in diabetic macular. Similarly, in pathophysiology of CNVM, there is formation of hypoxia, resulting in formation of hypoxia inducible factor 1 alpha, which increases the transcription of VEGF-A as well as angiopoietin 2. So we already know that VEGF pathway, VEGF causes increase in vascular permeability and also angiogenesis. Apart from VEGF, angiopoietin 2 also helps in vessel wall destabilization as well as angiogenesis in correlation with that of the VEGF. Apart from these two, there is a complement-mediated inflammation and also integrin ECM signaling, which further amplifies the VEGF-related angiogenesis as well as fibrocellular proliferation, resulting in formation of choroidal neovascularization and formation of pigment epithelial detachments, and there is persistent exudation with fibrosis and geographic atrophy. So a brief thing about the VEGF family. So VEGF is not a single molecule. You have VEGF A, B, C, D, and E, along with placental growth factor. Of all the VEGF A is the most important factor, which is implicated in the angiogenesis. Like I said, angiogenesis is proliferation of new blood vessels from the pre-existing blood vessels. So this VEGF A primarily acts through receptors R1, there are three kinds of receptors, VEGF receptors, R1, R2, and R3. VEGF-A primarily acts through R2 receptors, most important in angiogenesis, and also partly acts through R1 receptors. VEGF-B as well as placental growth factor act through R1 receptors. So by acting through the R1 and R2 receptors, they cause angiogenesis, inflammation, vessel destabilization, resulting in vascular permeability and edema. So coming to the molecular structure of various anti-VEGFs available. So we have bevacizumab, also called as Avastin. This is a full-length monoclonal antibody. You can see this is a full-length monoclonal antibody having a heavy chain and a light chain with a variable length, constant portions. So hence the molecular weight is high, that is around 150 kilodaltons. Whereas ranibizumab is actually a fragment of a human monoclonal antibody. You can say there is a fragment of monoclonal antibody. Hence there is a molecular weight is lesser than that of the bevacizumab. Aflibercept is actually a fusion protein which has extracellular domains of receptor, VEGF receptor R1 and R2, which is fused to Fc portion of the monoclonal antibody. So hence it is called a fusion protein. Conbercept is also similar to aflibercept, containing the R1 and R2 extracellular domains fused with the Fc portion of the human immunoglobulin G1. Brolucizumab is actually a very small molecule. It is a single chain variable fragment which allows it for higher molar dosaging. Faricimab is again a full-length monoclonal antibody. However, it is a bispecific antibody specific to two components, that is the VEGF as well as angiopoietin 2. So coming to the pharmacokinetics of various anti-VEGF agents, we will discuss them under the following headings: the binding affinity, the potency, the vitreous T-half, and the clinical targets and the molar dose. Coming to the binding affinity, the affinity to bind to its targets, that is a VEGF or the VEGF-A especially, is highest with the aflibercept, followed by brolucizumab, followed by ranibizumab. The faricimab, the affinity is similar to that of the ranibizumab. So the higher the binding affinity, more is the potency also. And also the potency is nothing but the minimum concentration that is required to produce a desired effect. So less is the concentration of the drug, means that it is a more potent drug. In the similar order like the binding affinity, aflibercept has the higher potency, followed by brolucizumab and ranibizumab. Coming to the vitreous T-half, aflibercept has about vitreous T-half about 7 to 10 days, whereas faricimab is around 7.5. Ranibizumab is again around 7 to 10 days approximately. Brolucizumab is around 3 days in the vitreous, and bevacizumab it is around 5 days. So with T-half means the amount of time required for half of the drug to be eliminated from the eye. So it is highest with that of the aflibercept. And what are the targets? So ranibizumab, bevacizumab and brolucizumab, all three target VEGF-A molecules. Even in the VEGF-A, there are 14 subtypes. The most important subtype is the VEGF-165 isoform. They mainly target the VEGF-165 isoform. But they target all the other isoforms also, but mainly the VEGF-165 isoform. Faricimab, like I said, is a bispecific antibody which targets both VEGF-A as well as angiopoietin 2. Aflibercept targets both VEGF-A, not only VEGF-A, apart from VEGF-A, it targets placental growth factor, VEGF-B, and also galectin-1. So this is a comparison of various anti-VEGFs. Like I said, bevacizumab is a full-length monoclonal antibody, ranibizumab is a fragment, aflibercept is a fusion protein, brolucizumab is a single-chain variable fragment, faricimab is again full-length monoclonal antibody but a bispecific. So various targets like we discussed, bevacizumab, ranibizumab target VEGF-A, aflibercept targets VEGF-A, B, C, and also placental growth factor. Brolucizumab again targets VEGF-A, faricimab, VEGF-A, and angiopoietin 2. So what is the durability of these agents? With bevacizumab and ranibizumab, the clinical trials show the durability are about 4 weeks. With aflibercept, it is around 8 weeks. Brolucizumab, it is said to be around 12 weeks. In faricimab, it is said to be about 16 weeks. The dosing interval can be extended up to 16 weeks after the initial loading dose. When it comes to intraocular inflammatory rates, the highest is with that of the brolucizumab. Because it's a smaller molecule, there is which allows it for higher molecular dosaging. So more risk of immunogenicity and more chances of intraocular inflammation. When it comes to systemic suppression of VEGF, that is in the body, the suppression of VEGF, it is highest with that of the aflibercept and least with that of the ranibizumab. So we already know that VEGF is the main pathway in angiogenesis as well as in vessel wall destabilization and vascular leakage. But there are other additional pathways like angiopoietin 1 and 2 pathways, integrins, hypoxia-inducible factor alpha, and the complement-mediated inflammatory pathways. So could targeting these pathways improve the efficacy or visual outcomes in these patients like DME or NAMD patients is what we have to look. So we already know that in patients with diabetic retinopathy or in DME or in neovascular AMD, both VEGF-A as well as placental growth factor are quite upregulated. You can see here it is upregulated to 61 times the normal levels in patients with DME, the VEGF levels, whereas placental growth factor levels are upregulated to 19 times the normal values in patients with DME. After one injection of aflibercept, you can see the drastic reduction in the VEGF levels as well as placental growth factor levels with aflibercept. So this is the aflibercept molecule. Like I said, this is the R2 extracellular domain portion, and this is the R1 portion. This is the FC portion of the immunoglobulin G1. So VEGF2 receptor binds to VEGF-A, and VEGF1 receptor binds to VEGF-B as well as placental growth factor, thereby reducing the inflammation, decreasing the vessel wall leakage, and also decreasing the angiogenesis. So the other pathway, like already discussed, is the angiopoietin 1 and 2 pathways. Angiopoietin 1 is actually important for endothelial homeostasis, survival, integrity, and stability. This angiopoietin 2 is actually the antagonist of angiopoietin 1, acts through tyrosine kinase 2 receptor in the cell surface receptor tyrosine kinase 2, causing vessel wall destabilization, increased permeability, and angiogenesis. This angiopoietin 2 is also implicated in inflammation and also fibrocellular proliferation. So could targeting this angiopoietin 2 pathway relevant for the treatment in NAMD or in DME patients, whether it increases the visual outcome is what we have to look into. The main important factor to look into angiopoietin 2 pathway is the biological effects of angiopoietin 2 is dependent on the concomitant VEGF levels. Like what we see in a normal VEGF state or in a patient who is already treated with anti-VEGF agents where there is already a suppression of VEGF, that is low VEGF states, the angiopoietin 2 actually causes vessel wall regression. So there is not much role in patients who are already on anti-VEGF monotherapy or in normal VEGF states. So this angiopoietin 2 only acts or supplements the action of VEGF in high VEGF states. So it promotes VEGF activities like vessel wall destabilization and angiogenesis only when the VEGF levels are higher. So there are two kinds of angiopoietin 2 inhibitors that have been studied. So one is nesvacumab, developed by Regeneron. This is mainly an oncology drug. So this is said to be more potent inhibitor of angiopoietin 2 than the faricimab. And this along with the aflibercept 2 mg has been studied in the Ruby and Onyx study. So the fixed combination of, and it is actually a fixed combination along with the aflibercept. So nesvacumab 3 mg or nesvacumab 6 mg is combined with 2 mg of aflibercept and compared with anti-VEGF monotherapy, that is aflibercept 2 mg. So since this is a fixed combination, it allows delivery of both the agents, that is the angiopoietin 2 inhibitor as well as VEGF inhibitor in different ratios and also in different specific doses. However, faricimab, which is developed by Roche and also FDA approved for DME and NAMD, is a bispecific antibody and it does not allow any flexibility in dosing the molecule. So binding is also limited since it's a single molecule, it's a bispecific antibody. Each molecule can either bind to VEGF or angiopoietin 2. So like already previously discussed, like in Ruby and Onyx studies done for DME and neovascular AMD, combination of nesvacumab with aflibercept in different doses, the 3 mg and 6 mg, with comparison to aflibercept 2 mg did not show any visual acuity improvements or no additional visual acuity benefits in comparison to monotherapy with aflibercept 2 mg. So the studies with faricimab, the Yoshimite and Rhine study done for DME and also Tenaya and Lucerne study done for neovascular AMD. This is actually a non-inferior study. This is not a superior study. So the endpoint was the faricimab was non-inferior to aflibercept. That means it did not show any additional visual benefits in comparison to aflibercept. However, the dosing intervals after the initial loading doses has been extended to 12 to 16 weeks in 80% of the patients is what is seen in these studies. Similarly, Avenue clinical study comparison between faricimab as well as versus ranibizumab did not show better suppression of angiopoietin 2 by faricimab over ranibizumab. So the level of angiopoietin 2 inhibition was similar between faricimab and ranibizumab, and also the visual acuity gain, that is the primary outcome, is faricimab failed in showing better visual acuity in comparison to ranibizumab in this study. So this shows that additional suppression of angiopoietin 2 may not be much benefit in comparison to anti-VEGF monotherapy in terms of visual acuity gain. As we already discussed, since angiopoietin 2 expression is dependent on the VEGF levels, so and a patient who is already on anti-VEGF therapy, anti-VEGF monotherapy may not have additional benefit with suppression of angiopoietin 2. So this is a study which shows that of all the agents available, ranibizumab, brolucizumab, and aflibercept, the maximum suppression of angiopoietin 2 happens with aflibercept. You can see the diagram where after 1 month of injection, the levels of angiopoietin 2 is maximum suppressed by aflibercept, followed by brolucizumab, and followed by ranibizumab. Similarly, at 56 days after the anti-VEGF injection, maximum suppression is again seen with aflibercept group. So this is again the same slide. Aflibercept has highest binding affinity, is more potent than other anti-VEGF agents, has approximately 7 to 10 days of T-half, and has multiple targets. Hence, it is considered as the most potent and robust suppressor of VEGF. So coming to the guidelines in the treatment of DME. So DME can be classified into center involving DME and non-center involving DME based on OCT findings. So center involving DME, the first line treatment would be anti-VEGF agent. So anti-VEGF agents course over laser. So the current treatment guidelines suggest that anti-VEGF is the first line of treatment. Which anti-VEGF to be chosen? You can take a guide from the protocol T of DRCR.net. So when the visual acuity is worse than 20/50, the aflibercept scores better in comparison to bevacizumab and ranibizumab. However, when the initial visual acuity is good, all three agents are equally good for treating DME patients. In case of non-center involving DME, laser or anti-VEGF therapy has to be chosen. So aflibercept is one molecule which, when you use in clinical practice, can produce outcomes similar to what we see in trials. That is what is seen here. So the newer molecules, the newer generation of anti-VEGFs, the second generation of anti-VEGFs like brolucizumab or the faricimab. The problem with brolucizumab is the safety profile. Aflibercept has a very good safety profile, and long-term safety has already been established. The problem with brolucizumab is the safety, that is intraocular inflammation, as seen in Hawk and Harrier studies, it's around 4.1, whereas in Indian population it was quite less, around 0.79%. But a careful selection of patients has to be made before giving the injection of brolucizumab. So you cannot combine with the cataract surgery. You have to rule out any previous uveitis patients or any inflammatory pathology. And once any inflammation comes, you cannot reintroduce brolucizumab in such patients after intraocular inflammation followed by first injection of brolucizumab. So when compared to brolucizumab, the safety of aflibercept is very high. The other second generation molecule, like we discussed, faricimab, did not score much in terms of visual acuity in patients, in both the patients, DME and NAMD patients. So the newer molecules to be developed, we look at increasing the dosing interval. So hence, aflibercept 8 mg has been FDA approved for NAMD and DME in 2023. However, it is not currently available in India. The advantage with 8 mg aflibercept is the clearance of ocular clearance when compared to the 2 mg aflibercept is quite slower. It is 4% slower than that of the existing molecule. So the PULSAR study for wet AMD and also PHOTON study for DME confirms its already established safety and efficacy. However, the dosing intervals can be extended. What was previously 8 weeks with aflibercept 2 mg can be extended to 12 and 16 weeks after the initial loading doses, is what we see with aflibercept 8 mg. So it could be a game changer if available. So the other molecules or other targets which are under trials are the tyrosine kinase inhibitors. The complement-mediated inflammation results in upgradation of the tyrosine kinase, intracellular tyrosine kinase. So inhibiting this tyrosine kinase in both DME and wet AMD, these are the following molecules: sunitinib, oralanib, and axitinib, which are under phase 1, phase 2, and phase 3 trials for both DME and wet AMD. These have to be given after the initial resolution of edema with anti-VEGF agents. So once a year treatment with these agents can actually increase the dosing interval or prolong the duration of the treatment. Other molecules like VEGF-C, VEGF-D trap, sometimes what happens is a patient who is on anti-VEGF therapy for quite some time, despite of having anti-VEGF suppression, persistent fluid or recurrent fluid happens. This may be because of the upregulation of VEGF-C or VEGF-D in such patients, resulting in the persistent fluid, which does not go away with multiple anti-VEGF injections. So in such patients, along with anti-VEGF monotherapy, combination of VEGF-C or D inhibitor like sozinibercept can address the problem of persistent or recurrent exudation despite the chronic VEGF-A suppression with anti-VEGF monotherapy alone. So other targets could be integrin ECM signaling pathways, also hypoxia-inducible factor alpha pathways. However, the problem with these molecules is they have high clearance from the eye. So their effect could be short-lived. However, they're still under trials. And also the gene therapy is being done. They are also under phase 2 trials. So they introduce a molecule, a gene, into the subretinal space or intravitreal space, producing a molecule similar to aflibercept or ranibizumab. So these are all under the trials. So whatever trials of late are being done is to increase the durability of the treatment or increase the dosing intervals. So to summarize, up to date, whatever anti-VEGF molecules we have for treatment of various retinal disorders, and aflibercept scores better in comparison to other molecules in terms of efficacy, safety. So there is no additional benefit in targeting alternative pathways like angiopoietin 2 as of now. Thank you.
Thank you, ma'am. Thank you for the elaborative presentation. So I have a question, like in your experience, which patient subgroups benefit most from the aflibercept, like diabetic macular edema, vein occlusions, or neovascular AMD PCV? Which subgroup?
So all three groups actually, even DME patients and vein occlusion, and especially in vein occlusion patients who need multiple injections. DME patients, at least they are little, they don't need that many injections or maybe not requiring so many loading doses. Vein occlusion patients and neovascular AMD patients, they do require these loading doses. So those patients definitely, aflibercept works better in comparison to other molecules.
Okay, ma'am. Then, in case of treatment naive DME patients, what factors make you think of aflibercept over the other anti-VEGFs?
Like I said, if economics is not a factor, I would definitely start with aflibercept in comparison to, since it's a established fact that it is a better molecule in comparison to ranibizumab, like we see in protocol T also. So when initial visual acuity is also very important. If initial visual acuity is better, like 6/9 or 6/9 parts, or if it is 6/6 and you should treat the patient, that time you can give any anti-VEGF. But if initial visual acuity is far worse than 20/40 or 20/50, aflibercept scores better.
In any case of any OCT biomarkers, you choose aflibercept over other one?
No. For aflibercept, I do not choose OCT biomarkers, but where sometimes for giving steroid as a primary treatment, that time I would look for OCT biomarkers. But OCT biomarkers not alone, But if patient has any problem with systemic problem, that recent MI or recent stroke, or a patient is a pregnant patient or breastfeeding patient, in such cases, or there is hard extrace very close to the fovea, that is when which I'm a bit scared of giving anti-VEGF agent, because they act very fast. So there is actual chance of migration of these hard extrace into the foveal region and later on causing fibrosis. So those patients I would definitely would like to give corticosteroid. And also when we have to combine cataract surgery with a patient who is having DME, those patients also I would like to give corticosteroid, unless it is a PDR patient or a very severe NPDR patient, where I think combining with anti-VEGF agent with cataract surgery would be beneficial rather than with the corticosteroid.
Interesting. Yes, ma'am. Thank you, ma'am. Thank you. So, not only because of molecular characteristics, by decreasing anti-VEGF and the placental growth factor levels, aflibercept is a drug of choice because of its safety
Definitely.
profile also.
Yeah.
So, but being a premium anti-VEGF, like its cost is high, so most of the patients are not affordable previously. Now the
Correct.
price has reduced, so most
Reduced
patients
considerably.
can avail aflibercept now. So, and what do you think of aflibercept biosimilars, ma'am? Most of them are coming.
True.
So,
They have already entered into the market, but we need to see if they produce a similar efficacy like aflibercept. That is what I have no personal experience with Anira so far, but we need to see if they produce similar efficacy, then it would be a game changer, because the economics are going to further come down.
yes. And the introduction of 8 milligrams of aflibercept.
That would be a game changer, I feel.
Longer intervals, injection
Because
intervals.
whatever said and done, we already know some molecules have great efficacy. It is not the efficacy at this point of time that we are looking at. We have molecules with good efficacy and good VEGF suppression. All we want is, we don't want patients to keep on coming, keep on giving injections. Because of this, non-compliance is a problem. So we want a molecule which works for a longer duration of time. So definitely aflibercept 8 mg might be a game changer.
Yes.
Clinically, if it translates.
Okay. Thank you, ma'am. So, Srinivas, any questions from audience?
Yes, ma'am. Dear doctors who are attending the meeting, if any questions are there, you can unmute and ask, or you can enter in the chat box. Madam, we'll wait for 1 minute.
Okay.
So as of now, there are no questions in chat box as well, madam. If any final comments from both the speakers and you, then we can close the meeting, madam.
Nothing from ma'am, you're on mute.
My experience with faricimab is quite less, maybe probably like 5 to 6 injections. Did you notice any, like they say, extended dosing interval of 12 weeks or 16 weeks after the initial loading doses? Did you notice that for either in DME patients or in CNVM patients?
Even I don't have much experience with faricimab, no.
Whatever I
have a
have given are not treatment naive patients, actually. I have either shifted them from other anti-VEGFs or in both DME and CNVM. So I don't have any treatment naive patients. So I just wanted to know. Dr. Divya, do you have?
Chronic DME, I mean, nothing worked. I have given all injections and previously treated elsewhere. But after giving faricimab, that cystic space has resolved. I mean, that edema got resolved, but visual acuity is same. There is no
Okay.
difference. So,
There's
So,
only slight
fine.
decrease in the edema, ma'am. Like I have maybe previously given maybe 4 injections, not more than that. But I have given in treatment naive also. Edema has decreased, but it is not that significant, or the interval which we are keeping is not that long. So it is not
Okay.
acting for long, like as it is
What they
claimed to
claim.
be for 12 weeks or something, but
Yeah,
it is
16
in
weeks.
real life, it is not up to 12 weeks.
Okay.
So great, madam. I would like to convey my heartfelt thanks to today's moderator, Dr. Lakshmi Prasanna madam, and today's two great speakers, Dr. Sweta madam and Divya madam, Sai Divya madam. So it was a great scientific conversation and discussion. We would love to conduct such sessions in future as well with your cooperation and support. Thank you so much, madam. Thank you so much, and have a great evening ahead. Thank you.
Thank you,
Thank you,
Bayer,
Ma'am
for giving me
Srinivas.
this opportunity.
Thank you so much, ma'am. Pleasure is mine.
Good night, everyone.
Good night. Hi, tech team. You can close the meeting for all.
Okay, sir.